Could we start by asking you to tell us a bit about yourself and how you got interested in the field of addiction?
Yep. Well, thank you very much for the invitation.
Mm-hmm.
Delighted to participate. Um, yeah, I'm a graduate of Glasgow University Medical School, and when I left the medical school, I had no idea that I was going to go on and have a
Mm-hmm.
career in addiction medicine.
Mm-hmm.
It was really when I was training in general practice. I was training in an area of Greater Glasgow that had quite a lot of deprivation, and we saw people with significant alcohol and drug problems in the late 80s, early 90s. And it was there that I developed an interest in addiction medicine, particularly in drug treatment. And from there, I started doing some specialist sessions in the specialist alcohol and drug services, Glasgow Drug Problem Service, as it was called then. And before I knew it, my GP sessions started reducing, and my interest in the specialist field grew. And by 4 or 5 years later, I was working almost exclusively in alcohol and drug services.
Mm-hmm.
It's very rewarding to work there, and one of the things that attracted me
Mm-hmm.
was that actually it was such a visible and important problem in the communities where I was working as a GP, and an area that needed medical input to make a difference. Um, Also, just at a personal level, I really enjoyed working with the patients. And actually, once treatment was established for them and they had a degree of stability in their lives, there was a sort of remarkable improvement in their health, in their social functioning, and a sort of response to treatment that you don't often see in other chronic diseases that you're dealing with in primary care.
Mm. Thank you. The next question is: do you think there's anything distinctive about the nature of addiction problems in Scotland? And if so, what would you say?
Well, as we all know, unfortunately, Scotland has an unenviable reputation with regards to outcomes linked to drugs and alcohol, and probably unmeasured in other addiction fields as well. So, some behavioral addictions like gambling, I actually
Mm-hmm.
don't know the data, but I imagine that things are difficult there as well. My specialism is around drugs, really, drug treatment and drug trends. And undoubtedly, we see in Scotland not only some of the worst outcomes in terms of drug related deaths and other drug related harms, but also some of the drivers to that. So, some of the drivers to that are obviously some societal, um, social determinants, poverty, people starting off with really difficult life circumstances. We know that increasingly, we know that adverse childhood events and trauma play a part in people's life journeys into problem substance use. But the patterns of substance use, the drugs that are used and the substances that are consumed, are somewhat different from other parts of the world. So, historically, and certainly what we've been dealing with in the last 20, 30 years, has been that combination of opiates, street heroin, maybe prescribed opiates as well, and benzodiazepines and alcohol. So, all downers as
Mm-hmm.
such. And all of those in combination and polysubstance use has been sort of an important driver of the harms that we're seeing. Now, we've had I've done some work with the European Monitoring Committee on Drugs and Drug Addiction, which is now called the European Drug Agency. And actually, that pattern isn't exclusive to Scotland. So it seems to be the more north you go in Europe, the more that sort of that those drugs become the drugs of choice, and combination of depressants becomes more and more popular. But I think what's clear is that in Scotland, there's the numbers of drugs involved, the amount of depressants involved, do drive some of the harms that Scotland experiences and make it an outlier. In recent years, though, fascinatingly, in recent years, we're seeing quite a significant trend in street drug use. Sorry, we're seeing quite a significant change in the trends in relation to street drug use. So heroin is becoming less used, less popular, and we're seeing a rise in cocaine, including injecting of cocaine as well. So there seems to be a drive moving towards stimulant use as well. So I think that historical pattern is changing. It'll be really interesting to see both what sort of harms emerge from the stimulant use and also what we can do in terms of treatment options. As you know, for opiate use, for heroin use, we had substitute prescribing with methadone, buprenorphine, Buvidal. Now we have heroin-assisted treatment in Glasgow. But for cocaine, there isn't such an evidence-based substitute. And I think the challenges ahead for us as clinicians in the field are going to be how we support and treat people with cocaine
Mm-hmm.
dependency.
Mm-hmm. I was interested in the point you made earlier about Northern Europe, how the problems. Any hypothesis about that, or lack of daylight, or?
So, believe it or not, I mean, when we try to understand the drivers for that,
Mm-hmm.
I think actually really basic things like winters, long
Mm-hmm.
winters, daylight,
Mm-hmm.
cultural, long-standing cultural factors, the importance of alcohol as a historical element in
Mm-hmm.
society, and the effect of that sort of depressant effect
Mm-hmm.
of alcohol seems to be the only things that we can really sort of point to. But they're tentative, aren't
Mm-hmm.
they? They're
Mm-hmm.
difficult theories
Mm-hmm.
to prove. The When we compare drug patterns in the north of Europe with sort of Mediterranean, the Mediterranean pattern was less about polysubstance use. It was less harmful behaviors. It was heroin or cocaine, but not heroin, benzodiazepines,
Mm-hmm.
alcohol all together in very,
Mm-hmm.
very sort of
Mm-hmm.
harmful ways.
Mm-hmm.
Though we see, though, from the monitoring data that it's emerging, that it may be that in Europe, benzodiazepines and the new atypical benzodiazepines that come from the illicit market are possibly now emerging and in those parts of Europe where they weren't such a big feature before.
Mm-hmm. Thank you. So the next topic is decriminalisation. What are your views on that?
So, I mean, as a clinician, I try to just stay out of the criminalization,
Mm-hmm.
decriminalization, legalization, or not debate in the public. But since you've asked
Mm-hmm.
me, um, I do think that one of the drivers to drug related harms is the impact of people not seeking help because they're they're worried about the involvement of the criminal justice system in their lives, and also the fact that actually criminalizing people who have chronic disease from dependent drug use actually does not support them to recover and does not help them to get treatment and to make forward progress. And you can see across the world that the war on drugs is lost and was lost a long time ago. So we do need to take, I think, a different approach societally. It's sometimes difficult for politicians and policymakers to take the steps that are required. And it's not just a national discussion because of the international flow of drugs, the international market in heroin, cocaine. There's an international sort of discussion to be had about how we regulate drug markets meaningfully in the future. So we're I was delighted that some years ago now the Scottish government moved drugs policy from crime and justice to health, because I think that's where we can make the biggest difference in terms of supporting individuals, improving the public health, and having a go at some of the social determinants that drive the poor health outcomes. Now you'll see that I'm kind of avoiding the question, yeah,
Mm-hmm.
because I'm not sure what we mean. I'm not sure there's a definition of
Mm-hmm.
decriminalization.
Mm-hmm.
I don't think it's so easy to say let's decriminalize drugs. I do certainly think that what we could be doing is supporting more people who experience problem drug use to get support rather than be punished for that. Even in Portugal, actually, people, it's not that drugs are legalized, it's that people are given an option when they run into problem drug use and the criminal justice system to come into a health and treatment model rather than go down the
Mm-hmm.
route of further punishment through the
Mm-hmm.
criminal justice
Mm-hmm.
system. But the legal framework is not
Mm-hmm.
decriminalized the
Yeah.
drugs, as
Yeah.
far as I
Mm-hmm. Yeah.
understand it.
No, no, no. Thank you for that. And the next topic is what would you like to see change in our approaches to addiction? And I think you've answered some of that already.
Yeah, so I think both at a societal level and from a medical professional level, I think we need to understand that um, people who experience addiction are experiencing a powerful health problem. Now, it's not solely a health problem. I understand that absolutely there are social determinants, as I described earlier, and there's a lot of psychosocial factors that play into people experiencing severe addiction problems. But actually, there are ways to support people through a health approach. And I think we need to be, all of us, mindful of the public health impact of addiction in Scotland, and that addiction therefore is every physician, psychiatrist,
Mm-hmm.
doctors, health workers business. That's not to say that everybody should know how to treat all addictions, but everybody should be play their part. Now, what does playing their part mean? It doesn't matter which part of the health system that you work in, but if you approach people in a trauma informed way, in a psychologically informed way, if you understand inequality sensitive practice, if you understand that some of our health setups and practice can be quite stigmatizing and in fact traumatizing for people with addiction, then I think you're on a journey to being able to engage people who often find it difficult to engage in health services but desperately need the support of health services. And I think from a societal level, I think we've really got to sort of challenge the poor understanding of the drivers to addiction. It's not a lifestyle choice for people. They're not guilty of having chosen this path. And we have to understand that we've got a role to not just not contribute to stigma but to fight stigma, um, and I think to pressure our politicians and our policymakers to create a society in which people grew up not in extreme poverty and have good life circumstances when they start in life, and grow up in social and psychological environments that allow them to flourish rather than flounder, which is what often
Mm-hmm.
happens for many communities in Scotland.
Mm-hmm. Mm-hmm. Thank you. Thank you. And I think you've answered the next question to some extent as well. It's the future of addictions. How do you think it will look in a few years down the line in Scotland?
Yeah, so I mean, obviously, addictions is a very broad
Mhm,
term, and under it comes many
mhm,
different subcategories of addiction. From a drug treatment point of view, as I said earlier, I think we're seeing a shift in the pattern of drug use in Scotland, and I think we need to understand what we can do to support people who are using cocaine in a problematic way in very increasing numbers with significant public harm, the public health harms that are linked to that. So I think we'll see our drug treatment services hopefully so be able to meet that challenge in coming years. I think from an alcohol point of view, so in the last 10 years, there's been such a focus on the drug deaths emergency, understandably, that it's possible that perhaps we have taken our eyes off developing our alcohol services or meeting the public health challenge around alcohol. Um, and also in terms of developing alcohol treatments and bringing new approaches and medicines and interventions in, I think we haven't seen significant change in the field for a while. So I would really like us to be able to progress around alcohol, but there are a whole range of other addictions that are developing in Scotland, and I think the behavioural addictions in the world are really causing a lot of harm to individuals and communities. So gambling, for example, um, internet and technology
mhm, mhm,
addiction.
mhm,
So those aren't things that I think somebody like myself is necessarily going to sort of engage with, but it is something that I think we as a society need to meet the challenge of, and particularly from a psychology point of view,
mhm,
be able to support people to recover from those.
mhm. Okay. The question, well, again, you've answered it, or part of it anyway, about from your clinical experience. What are the rewards? And you've said what they are. But what are the challenges, though, in your field, as a clinician?
Yeah, I mean, just to go over the rewards again quickly. I was just speaking to somebody yesterday who doesn't work in the field at
Hmm.
all, and they were saying to me, how do I deal with the behavior and the violence? We don't experience these things. If you approach people in a psychologically informed, trauma informed, non stigmatizing, non judgmental way, then my experience over 20 years of seeing hundreds, if not thousands, of patients in that time, I can think of only a handful of occasions where I've run into problems. And actually, I've really enjoyed and learned a lot from our patients. Their resilience, their survivorship is is quite inspirational. Um, the challenges undoubtedly are that although I'm strong to emphasize that we need to take a health based approach, people's problems aren't just a health based problems, they're multifactorial. So people are that we're seeing are dealing with poverty, they're dealing with really broken down relationships and isolation, deeply entrenched stigma and shame, and a whole host of other psychological and mental health problems. And the challenge for us, and some of the sort of disappointments, is that when we make progress in one field, something happens somewhere else, and really impacts our patients adversely. And so you need to have a sort of a lot of resilience yourself as a clinician in the field, because you're seeing sort of social precarity and harm on a front row seat. And so you need to be wary of that, and think about the long term for the patient. But yeah, they have a huge host of challenges. I think as a clinician and as a service, of course, in Scotland, the impact of drug and alcohol use on the burden of disease in Scotland is massive. But I don't think our funding or our resources are at all equivalent to
No. No.
to the size
Mm,
or the
mm,
scale of the
mm,
problem.
mm,
So I think I've always felt that the we've tried to give as much coverage of a
mm,
treatment
mm,
service as possible,
mm,
but sometimes the quality and the therapeutic impact of that at times is challenged by the fact
mm,
that we just don't have enough
mm,
resources to do that.
mm. Yeah, sure. And the question about key messages to other clinicians, other people in the field, I think you've answered that as well, but I don't know if there's anything you want to add, or you don't have to.
So you'll have followed in the media that we've recently set up a drug consumption facility in Glasgow. Um, and when we were designing the building, we spoke to people with lived experience and living experience in problem drug use. And the feedback was really interesting about things like the setup. They did not want clinically sort of looking places because the experience of clinical places has not been positive in the past. Emergency departments, GP surgeries, inpatient wards,
Mm,
they've they've not experienced a, a, a positive outcome in those places most of the time. They wanted us to change the names of consultation rooms to chat rooms, treatment rooms to health rooms, because they associate consultations rooms, treatment rooms with, challenges that they've had in the past. So for them to have ownership of the place, they wanted it to look different. They wanted the names to be different, the language to be different. And I suppose that tells us something, doesn't it, about how our current health systems um, are unable perhaps to engage with marginalized communities in the way certainly that myself and many of my colleagues would like. And I think, whether you're a manager, whether you're a clinician in the health and care system, um, we should all be making a contribution to improving, not just meeting everybody's needs, but improving uh, the uh, the public health outcomes in Scotland.
mm,
And unless we engage with some of the people who have the worst outcomes, then how are we going to do that? So I
mm,
think there's
mm,
that sort of non-stigmatizing, non-judgmental, trauma and psychologically informed approach. I would ask everybody to think about this
mm,
when they're designing and
mm,
renewing their services.